So people who exercise regularly develop a constellation of structural and functional changes that promote the generation of a large cardiac output for a prolonged period. In order to do so, athletes who exercise vigorously get big cardiac dimensions. So 48% of male athletes have an LV cavity size of more than 54. 24% have an LV cavity size of more than 60. The basal RV is enlarged in 57% of male athletes, and the RVOT is enlarged in 40% of athletes. The prevalence of left ventricular wall thickness, in contrast, is not as high as the prevalence of ventricular cavity enlargement. Here is a study from Italian Olympiad studies, athletes, which looks at the distribution of wall thickness measurements in male athletes, blue bars, and female athletes, the red bars. And you will see that the distribution of LV wall thickness is such that the vast majority of athletes have a wall thickness of 12 millimeters or more. However, an important minority, that is 2% of male athletes, have a wall thickness exceeding 13 millimeters and up to 16 millimeters, which overlaps with morphologically mild hypertrophic cardiomyopathy. You'll see here that the females do not develop a wall thickness of more than 12 millimeters. So this conundrum is focused on males only. Even if you look at LV geometry, we find that whereas males and female athletes normally have normal geometry, concentric hypertrophy and concentric remodeling is much more common in males than females. This is a much bigger study of 3,500 white athletes, which again shows that an important minority, only 1.5%, have a left ventricular wall thickness that overlaps with hypertrophic cardiomyopathy. So if we look at the demographics, we normally see this LVH in male athletes who are adult, who are large, and who engage in endurance sport. But speaking from the UK, where over 30% of our athletes are African or Afro-Caribbean in origin, we've got to take into account ethnicity. Now, here is data in 800 white athletes and 904 black athletes from UK and France. And you'll see, whereas only 1.6% of our white athletes have a wall thickness of over 12, 13% of black athletes have a wall thickness in this gray zone. But the other thing I want you to appreciate is that no matter what your ethnicity, it's very uncommon to have a left ventricular wall thickness of more than 15 millimeters. So if you see a wall thickness of more than 15 millimeters, consider that as pathological left ventricular hypertrophy. Clearly, when we are faced with a potential differential diagnosis of hypertrophic cardiomyopathy in an athlete, we've got to get the diagnosis right, because an erroneous diagnosis has significant consequences, including unnecessary disqualification or even potentially jeopardizing a young life. So let's look at the pattern of hypertrophy. It's very easy when someone's got asymmetric septal hypertrophy or hypertrophy confined to the apex. That's very easy. However, sometimes an athlete has this concentric pattern of LVH, and this is where the differential diagnosis becomes important. So here is an echocardiogram of a professional athlete. So you've got the conventional views, and you can see if we put the measurements in, the septum's 14 millimeters, posterior wall 13 millimeters, short axis views 12 millimeters, and you do not see a more than 2 millimeter difference between adjacent segments. So athletes normally have very homogeneous wall thickness measurements where there isn't much asymmetry. And in general, athletes that have LVH of between 13 and 15 have big cavities, because in physiological LVH, the wall thickness is a result of an increased cavity size to maintain wall tension. Whereas in pathological LVH, such as hypertrophic cardiomyopathy, hypertrophy occurs at the expense of the LV cavity. So athletes with LVH have big cavities. And that brings me to the left ventricular cavity size in relation to wall thickness. Here you've got an athlete with LVH and a hypertrophic cardiomyopathy patient who exercises a lot. Both have got minimal LV wall thickness of 13 millimeters, but the athlete's got an LV cavity size of 56 millimeters, whereas the individual with hypertrophic cardiomyopathy has an LV cavity size of 48 millimeters. And here we use the HR ratio, where the H is the sum of the septal thickness and the posterior wall, and the R is the LV cavity size and then diastole. The HR ratio in this athlete is 0.47. And although your textbooks tell you that the HR ratio of more than 0.42 is abnormal, in sports cardiology, we use a cutoff of 0.5. So if the HR ratio is more than 0.5, we think of relative hypertrophy, even pathological LVH. What about indices of diastolic function. Impaired myocardial relaxation is the signature of hypertrophic cardiomyopathy. There are various parameters, whether we look at mitral valve inflow, tissue Doppler, or pulmonary vein Doppler, that can help us differentiate between physiological LVH and hypertrophic cardiomyopathy. I'm not going to go through all of these in the best interest of time, but what I want to impress upon you is that no single index of diastolic function can actually differentiate between physiological LVH and hypertrophic cardiomyopathy in all individuals. Indeed, the conventional criteria that we use, such as E to A ratio, E prime, E to E prime, perform very badly in athletes who have hypertrophic cardiomyopathy. You can see here, the sensitivity of these criteria is only 5 to 35%, so lots and lots of false negatives. So if you've got abnormal diastolic function, you're on to win, because abnormal diastolic function has a very high negative predictive accuracy. But if you've got a normal diastolic function, it doesn't tell you very much. What about indices of systolic function? We know that hypertrophic cardiomyopathy is characterized by a small LV cavity with hyperdynamic left ventricular contraction. So if you actually look at radial contraction, such as ejection fraction and fractional shortening, people with hypertrophic cardiomyopathy have increased ejection fraction and increased fractional shortening, whereas athletes have normal ejection fraction and or slightly decreased left ventricular ejection fraction. For us at St. George's, we rely more on the mitral valve systolic annular velocity, and S prime of less than 10 would make us concerned in someone with hypertrophic cardiomyopathy. A global longitudinal strain of less negative than 11% would also make us concerned. Spectral tracking has an important job here. This is an athlete with normal global longitudinal strain. Here is an athlete with asymmetric septal hypertrophy. You can see there, someone with apical hypertrophic cardiomyopathy with a reverse bullseye pattern, and someone with concentric LVH. So I think spectral tracking is important in differentiating between the two entities. Sometimes, of course, all of you send your athletes away for 4 to 6 weeks to detrain. This costs them team selection, costs them their fitness, and they're pulling their hair out, and you're hoping that the hypertrophy will have regressed, and that's called physiology. We don't believe in detraining at St. George's, at least I don't, because what you're dealing with at the time that you've got the athlete with LVH and the abnormal ECG is that risk profile. When they detrain, it goes away, but when they retrain again, it's back, and you're dealing with that. So detraining doesn't really help me. What about like-for-like comparisons? Up to now, I'll be talking to you about elite athletes with LVH versus sedentary HCM individuals who are usually restricted from exercise. But in the UK, we actually respect athlete autonomy. So we've got lots of athletes who have hypertrophic cardiomyopathy and are competing at the highest level. So here is data from 106 high-level athletes with hypertrophic cardiomyopathy compared with sedentary patients with hypertrophic cardiomyopathy. And you will see that our athletes with hypertrophic cardiomyopathy have less hypertrophy than our usual patients with hypertrophic cardiomyopathy. They have bigger cavities than our patients with hypertrophic cardiomyopathy, and they have better indices of diastolic function than our sedentary patients. This is the important bit. 55% of athletes with hypertrophic cardiomyopathy actually have a left ventricular wall thickness of 16 millimeters, i.e. they just about fulfill the recognized international criteria for hypertrophic cardiomyopathy, which is a wall thickness of 15 millimeters or more. But 36% have hypertrophy combined to the apex, and this is the best news, that the true gray zone, that is concentric LVH, with a wall thickness of 13 to 16 millimeters is only 15%. Most athletes with hypertrophic cardiomyopathy have asymmetric hypertrophy. So this gray zone is nothing like as big as we once believed. What if we compare like for like, i.e. athletes with HCM and athletes with physiological LVH? You'll see that even compared with athletes with physiological LVH, our HCM athletes have a smaller LV cavity, slightly lower indices of diastolic function, but 13% have a big LV cavity that allows them to do what they're doing. Almost all of them have normal indices of diastolic function, but almost all of them have an abnormal ECG. So when in doubt and you're dealing with someone with LVH, put emphasis on the symmetry of the wall thickness, Don't put any emphasis on diastolic function unless it's abnormal. And remember that some athletes with HCM have a big LV cavity, but almost all of them have an abnormal ECG. So if you've got the ECG, go and look at it. This is a typical case that we see at St. George's. 19-year-old professional football player. You'll see mild hypertrophy at the apex of 14 millimeters, normally LV cavity size, apical cavity obliteration. But then you look at this ECG and it's game, set, and match, whether you do the MRI next or not. But this is where the MRI does become important. In fact, we MRI everyone that we diagnose with hypertrophic cardiomyopathy. But if you are financially constrained and you've got borderline cases like this and an ugly ECG like that, the MRI has an important role because it will show apical HCM. It will show LVH in the lateral wall that may not be picked up. It can pick up scarring, and it can even pick up myocardial ischemia during stress perfusion. So what I've told you is that there are lots of ways of differentiating between an athlete's heart and hypertrophic cardiomyopathy, and you can read this in your own time, lots and lots of ways. But remember, that gray zone of 13 to 15 millimeters is small. Only 15% of our athletes with HCM actually fit into that real gray zone. Remember that most have normal diastolic function. A small proportion have an LV cavity, but almost all of them have an abnormal ECG. Thank you very much.